Good afternoon, everyone. Is my mic on? Great. Hi, I'm Atman Loraki. I'm co-founder and CEO of Color. We're a population health company that works across large populations with both government as well as payers and life sciences companies. We're very excited today to have a talk about the future of diagnostics and biosensors. I'm going to, the way the flow is going to work, we're going to have Professor Alice Gass, or President Alice Gass, who's President of Imperial College, introduce our main speaker, who's will tell us all about biosensors, and then after that we'll swing into a discussion format and Q&A.
Thank you. Well, thank you very much. In the past century, we've seen tremendous advances in medicine. The development of antibiotics, advances in imaging and diagnoses have fundamentally changed the outcomes of many, for many diseases. This century, we're further accelerating this progress through integration of advances in physical sciences, along with engineering and life sciences and computing. Today we gather to discuss this exciting future of biosensors and diagnostics. We will hear about faster, more accurate diagnoses that can catch disease earlier when we can make a difference in outcomes. It is my pleasure to introduce Professor Molly Stevens, Imperial College London's Professor of Biomedical Materials and Regenerative Medicine, and the Research Director for Biomedical Material Sciences in the Institute of Biomedical Engineering at Imperial. Appropriately, Molly began her studies in pharmacy, receiving a first-class honors degree from Bath University and a PhD in biophysics from the University of Nottingham. Molly joined Imperial in 2004 after a postdoc in the laboratory of Professor Robert Langer at MIT. Amongst her very many accolades, Molly was elected Fellow of the Royal Academy of Engineering in 2013, and last year she was elected a foreign member of the U.S. National Academy of Engineering. She won the Institute of Physics Rosalind Franklin Medal and Prize and has been recognized by Technology Review magazine as one of their top innovators. Molly is also a trustee of the National Gallery. Molly has a large, very warm and dynamic and very multidisciplinary research group focused on fundamental and translational research for improving human health. She holds leadership positions as the director of the UK Regenerative Medicine Program Hub for Smart Materials and is deputy director of iSense, an interdisciplinary center focused on diagnostics for infectious disease. Her work is pioneering the design and development of ultra-sensitive diagnostics for applications spanning from cancer to infectious diseases. We look forward to hearing from you, Molly.
Thank you so much for the kind introduction and for the opportunity to speak here today. I'm going to be talking about biosensors and how we can use them to detect diseases earlier. If I could have the slides, that would be great. So if we think about all sorts of diseases, from cancer to heart disease, antimicrobial resistance, infectious diseases, these are all areas where early diagnosis of the disease can really help us in how we can treat the patients and help with patient survival, but also help in stopping outbreaks from spreading. Today, what I'm going to be talking about is mostly going to be in the infectious disease space, but I'll also give you a little taster of some of the work that we're doing in the cancer space right at the end of the talk. And if we think about the infectious diseases area, this is, of course, something that disproportionately will affect low-income countries. For example, HIV, AIDS, malaria, these are all extremely important diseases, as you know, Ebola, and really have a very devastating effect on these countries. And one of the things that we need to do to really help with this is to come up with diagnostics that can be more simple, cheaper, effective, and globally accessible. And this can really help us with democratizing access to healthcare. Extremely, extremely important aim. Now, you all will have mobile phones, and within our day-to-day life, we might think of these particularly for how we might use them for web searches and social media type applications. But they also have really, really important applications when we use them connected to lab tests and also as diagnostic tools. And these mobile phones are one of the ways that we can really help in democratizing access to healthcare by thinking of them really as portable mini computers. There's over 7 billion mobile subscriptions around the world today, enormous number, as you'll all be very aware. And this is a really, really important opportunity in helping us to empower people and to connect them around the world, and to also help in this very, very early detection of diseases. If we look at phones, of course, we can think about them in terms of phone calls and connectivity, but we can also think about the wireless connections and using them to be able to help with transferring data. And this is all the more important with the growing adoption of smartphones around the world. And if you look at smartphones, then even in places like sub-Saharan Africa, the uptake is increasing all the time, and more people are gaining access to these phones. And you can think about using them in really interesting ways as the capability of those phones grows. So, for example, people have used the microphone within smartphones for ecology mapping of mosquitoes. So maybe not the first thing that would come to mind, but really sort of interesting use of these technologies within the phone. Within our own group and our own centre, what we're interested in is using the camera capability of the phones. So thinking about how we can use these phones to capture images of the types of tests that we're going to be using for our biosensing. And we see this as a really important way in helping to democratise access to the healthcare. This is from a recent Nature paper that we published last year, where we looked at some data from Uganda. And the reason we chose Uganda is these data were readily available. And what we're looking at here is understanding the population that can be within 5 kilometres of a health centre. And this is a guideline that's essentially set by the Ugandan government. They'd like everybody to be within 5 kilometres of a health centre. And what we find is that whilst a lot of people can be within those 5 kilometres, there's a significant proportion of people that can't be. And yet within those people that can't be within that access distance, a certain percentage of them, not a significant percentage of them, will be within distance to a smartphone and to mobile reception that will enable them to use that smartphone. So this is a way that we can essentially access patients that might not otherwise be able to be accessed by the healthcare infrastructure. There's still a lot of issues with this. Mobile phone access, and particularly smartphones, is not equal across the population. Less women, for example, than men will have access. And also there's disparities in terms of the age of people within the population. People over 50 typically will have less access. But nonetheless, there's an opportunity here for us to be able to develop diagnostics that could utilize these phones and give access to diagnostic technologies to people that might not otherwise be able to access them. We have a wonderful centre in the UK called iSense. I'm currently the deputy director, and this brings together a number of different universities, a number of partners, also works together with a number of countries overseas. And what iSense is all about is about really developing ways and technologies to be able to much better detect and treat infectious diseases. And we have a focus in particular on infectious diseases, a number of different diseases, and I'll show you just a few examples of those today. But we think of this in different ways. So the first thing that we look at within iSense, and this is particularly work led by Ingemar Cox, is what we call tracks. So thinking about symptoms within a broader population for patients who perhaps haven't yet been diagnosed as very early signs of disease spread. The next part of the program is around the test, and that's all about detecting, being able to detect disease much earlier by developing new tools that can act as biosensing capabilities. And this is where a lot of my group focuses. So developing new types of technologies that can be a lot more sensitive than some of the things we currently have available. And then finally, very importantly, we have a treat section of the centre, and this is about how we can take those results, those diagnostic test results, and actually integrate them into the healthcare pathway. So thinking about online care pathways and also data visualization. So if I can give you just an example of some of the work that we've been doing, I'd like to pick on the example of early HIV detection. Even in South Africa, for example, in KwaZulu-Natal, you have about 30% of the population are infected with HIV. And this audience here, I'm sure, is very aware of the scale of this problem. One of the issues with being able to detect HIV in very remote locations, so outside of healthcare centres, is that the tests that have been developed are relying on the body producing antibodies to the virus. And so that means you've got a 3-week window at least before you can detect the virus. And the reason that you can't detect the virus immediately with these sorts of portable sensors is that they're just not quite sensitive enough. So we wanted to develop a test that would be able to detect the virus itself, and in particular detect some proteins on the surface of it called P24. And for that we're going to need new types of technologies that can give us really, really sensitive test results. We work a lot with nanoparticles, and by that I mean really, really small particles. So if you think about the size of the sun, you shrink it down to a football, and then you shrink it down by that amount again. That's the size scale we're talking about. So very, very small particles. And they can be made of different types of materials. But in particular, we're interested in materials that can give really interesting color changes so that we can come up with really interesting new biosensing capabilities. And what we can do is we can take those particles and we can decorate the surface of them with molecules that can bind to the virus. And so we'll be able to know if the virus is present. And these tests can take different forms. And this is just an example test, and many of these are developed within the center, where you can see that if you have a positive reaction, then you end up with a band across the strip. So this is a little bit like a pregnancy test, what a pregnancy test would look like, except it's much, much more sensitive. So you get a much, much greater amplification of the signal, and you can detect disease very early. Now, the idea is once you've performed this test, and this might be, for example, from a drop of blood from the patient, then you can get this test result and you can read it with a mobile phone. And when we're within the lab, for example, in London, and we have ideal lighting conditions, this is very simple, very straightforward. It's a bit more complicated when we move to the field, and I'll show you what we do to mitigate for that. Now, just to give you an idea of the sort of capability of these tests, what we need to be doing if we want to detect at the very acute stage is to detect virus at very, very low concentrations. Now, one of the commercial test limits that you can see here is essentially falling outside of that. And so the detection mechanism is actually not sensitive enough to detect the virus when it's at these very, very low concentrations. So these tests will work well once the patient's been infected for a while and has a higher viral load, but not in these very early acute stages. Whereas our test, because of the way that the particles themselves can amplify the signal, a very unusual way of doing that, we can end up getting into this acute stage. But this detection of the signal and the sort of positive result for the test is just not enough. What we need to do is to be able to have this integrated properly into online care pathways and get the patient the care they need. For example, in South Africa, there still will be occasions when a patient might be diagnosed with the HIV, and it might take up to a year to get within the correct treatment program. And so really that detection step is just the first bit of the journey. And it's about getting that patient then integrated properly into the healthcare system. And that's why it's very, very important for us to be working with fantastic partners out in South Africa. We work very closely with the Africa Health Research Institute. We've worked with them and we've trained over 60 of their community field workers out there. They've performed now over 40,000 tests of tests that both ones we've developed in-house, but also commercial tests. And the way we do that is we have developed these carriers for the tests that have various marks on them, so that when you take a photograph of them, either with a phone or an iPad, as you can see here, we have machine learning algorithms within our app so that you know the test result is really robust and you can actually really trust it. And this is something really, really important in terms of knowing that the data we get out of this is really reliable. These healthcare workers then work very closely within the community and are able to get the patients into care and to track them within that care and ensure a really a nice continuation from diagnosis through to treatment. If I give you another example, this is some result from a test that we developed that we took to Uganda. This was about looking at something called serological surveillance. So it's actually about looking at patients who have had Ebola and have survived and being able to detect between 3 different species of Ebola. And that's really important in terms of understanding how that disease is spreading within the community. And so we've developed these apps within the iSense Center. And developed the tests, these multiple marker tests, taken them out there, and we can then generate these geotag maps of how that infection is spreading. And this is really important in terms of understanding the spread of the disease and how you might control it. And other groups are also working on this sort of very important approach. So, finally, I mentioned at the beginning that I'd also finish off by telling you a little bit about some applications in cancer. And this is a really, really important area as well. It's slightly different to what I've just told you about in terms of the point of care testing, where we have tests a little bit like the pregnancy test, where you're working with a biological sample. This is some much newer work. This is still preclinical. And this is work where we have these same, well, slightly different, in fact, biosensing particles, but with that same sort of powerful ability to do the biosensing. And we use them inside the body to tell us about early disease inside the body. You can think about this for different types of diseases. I'm showing it here for cancer, but it might also be really interesting for things like malaria. And the way this works is that we are detecting proteins in the body called enzymes. Now, you all will have heard of enzymes in terms of the enzymes we have for digesting our food. You also have these enzymes for all sorts of other functions in the body as well. And in particular, if you have a cancer, what you find is that the level of specific types of enzymes will increase, and they'll be different to the baseline level you would have in a normal, healthy person. And what the enzymes can do is they can cut through molecules, and they can cut through molecules that are holding our particles together. And the particles will then disperse and become small enough that you can filter them through the kidney, and they end up in your urine. Now, this is work that we've done in collaboration with MIT. And what we find is that once these particles are within the urine in these preclinical studies, we can then add some very simple chemicals, and that urine will turn blue. And so you get this test, which doesn't need complicated equipment to read. You can just see it by eye. The urine will turn blue less than an hour after you start the test. And this is, we think, a really interesting way of being able to get this disease detection without needing, again, complicated equipment. So we should be able to also use these things within the field. So I'd like to finish just by bringing that together and really highlighting, I think, this very, very important opportunity we have to not only make sensitive diagnostics, but also to combine them with mobile technologies and really have this connected approach that can also feed into online care pathways and hopefully transform the way that we can treat patients within the community, both in terms of early detection, but also the treatment, disease surveillance, and hopefully even broader than that. There are a number of challenges, of course, around the data, and the systems have to evolve to be able to deal with that and the privacy with these systems. And we're very engaged also with ethicists and people within those communities to get this right. Thank you very much.
Fantastic. Thank you so much for running us through all of your work. This is fascinating, and I think one of the really exciting aspects of this window of time right now is that we're coming from a point where clinical care or caring for people's health was primarily based on acute care settings, right, where we wait until people get really sick and we take them to the hospital and we try to catch it at the very, prevent, catastrophic outcome at the very end. And what technology is doing right now is that it's pushing a lot of resources to the edges, right? Like the map that you showed in terms of, people within a distance of 5 kilometers to a healthcare center, but mobile phones are much more spread out, et cetera. And so I think right now we're seeing kind of that like decomposition of, the building blocks of, skill, sensing. Out of curiosity, what is the definition in your mind of the institution or the systems that are actually running these kind of this distributed health system that is going to happen? Like, it seems to be kind of like emerging in some sense, like, before, like the system that ran it was like, in the 4 walls of a hospital, if you will, and that encapsulated the piece of machinery that we have. But here you have all these sensors, you have all the distributed logic. Is it government? Is it more the hospitals? Like, what's the operating system that's going to be behind all of this?
It's everything together, really, isn't it? The technology, which is the bit that I personally specialize in, is of course crucial to get right, but it's only one part of the puzzle. And what we've found is that actually being able to really work with people locally that have the knowledge and the resources to be able to set up the infrastructure to then take those tests and get them connected. And within iSense, we also have a number of groups that have helped on data visualization tools as well. So for some of the existing HIV diagnosis cases that they do in KwaZulu-Natal, for example, they now can all be mapped within a dashboard system. And even that visualization, essentially, of how the disease is and how patients can be monitored over time, also for viral load and so on, is really, really crucial. So it's about that, but it's also about the evolving regulations that will need to be in place to enable these things to happen in a way that the patient privacy is taken account of, but you can also get people the best care. And so it's a framework that's not yet, as you know, yet sorted out. It's a very exciting time, actually, because it's all evolving in front of us.
So say we magically had all the privacy issues handled in some sense and that they were figured out. If, you were allowed to hack into everyone's phones for good, without in a way where they're all fine with the privacy, but your mission was to save as many lives as possible if you have complete access to their phone data, and to run anything on their phones. What do you think would be the highest impact applications?
I think the sort of things we're looking at, there could be applications, of course, for self-testing, and there's some examples within iSense in London, actually, around chlamydia, going right from patient self-testing through to sort of online care pathways. But actually, it's not just about that. It's also that the community healthcare workers can also be the ones that enable that sort of technology. It might not always have to be the patient themselves. So I think the setting is really important, and also making sure that whatever setting you have is appropriate for that particular disease, so that the patient can get straight into a treatment, has available counselling if that's necessary. So even if these tests might be easy enough to use by individuals, they might not always be appropriate to be used just by the individual without the care surrounding that. Makes sense.
And actually, on that point, there's been kind of, in mobile usage, for example, there's been a big leapfrog effect that happened in developing countries, where they almost skipped landline and kind of moved to mobile phones. Do you have a sense of like whether that's something that's going to happen in health? And if so, I mean, there's already some of the great examples you were giving. How that's going to happen, like, or what are going to be some of the driving forces behind that? Is it going to be primarily infectious disease, or is it going to be kind of more like public health?
I think it has important applications in both. Within our centre, we're a bit more focused on the infectious disease, but even the early work we're doing within the cancer, could also be very applicable in these areas. So it really, I think, doesn't need to be restricted to a very narrow healthcare application.
Sure. I have one more question, and then I think I want to make sure also we get some questions from the audience. Given that we're at WEF, and there might be kind of a country leader in the audience, if you had one country that was going to apply a regulatory framework that you think would be most effective at applying all the new science and technology that you're developing? What do you think are some of the biggest policy level or decisions that could actually make that happen more effectively?
So I'm probably not the best person to answer that question. We've got many more qualified people within our centre that are, specifically focused on both data privacy and cybersecurity, and also the ethics side of things. But it's very clear that the current legislations we have around GDPR and so on, whilst they have use, they're not enough to be able to handle these systems completely. And so working together very closely, as the people in our centre are, is going to be key going forwards. We need to keep having that conversation.
It's like the never-ending conversation, Any questions from the audience? We can open it up for...
Right, so one I wanted to ask you, with the new coronavirus which is around, what are the applications? The new coronavirus that is spreading now, does your work have applications there in containing the spread of the virus? And two, I have another question. In developing countries, like I come from India, a symptom of fever can be malaria, dengue, Zika. Lots of things could be just a bacteria. So how many things can a person test for when you're talking about self-diagnosis?
I think one of the things we're really interested in when we develop these types of technologies is actually making the technology itself be able to be very versatile. So we design them as what we call platform technologies, and the actual key component to it is the particles, if you like, that we make to have this very, very strong biosensing effect. But the way you then decorate them with different types of molecules means that you can target all sorts of different viruses or bacteria. So the amount of things that you want to detect, it really depends on how many tests you want to run in parallel, or whether you put several different markers on one test, and all of those types of things are possible. Your example about the fever is a really good one, because that can be so many different things, some of which are completely life-threatening and some of which are not. And so we're working very closely also with networks that have been set up to look at how we can tap into those sorts of populations and test the tests that we're developing. And then the coronavirus, I think there's a statement definitely coming out this afternoon, from what I understand. It's going on maybe during this talk even. So that's obviously a hugely important health issue right now.
When you increase the number of people that you test, when you increase the number of people you test, what about then the tremendous increase in false positives and what that can create?
That's obviously going to be a consideration for any test. So when we develop our test for biosensing, we're specifically looking actually for acceptable levels of false positives, and we would not consider a test to be satisfactory unless it had very small numbers of false positives. So that would be one of our criteria in the test design.
I think actually one thing also is I think one interesting evolution that's happening now with the ability to generate massive amount more data for each individual is that I think historically the model we think about testing is like there's no statistical prior. Every test almost stands on its own. We're not operating in a Bayesian model, and every test needs to have a PPV effectively almost that gets it over a threshold that says, okay, now we can do something about it. And for example, we deal with this a lot in the genomic space where there are a few cases where there's a sufficiently high threshold of evidence to say, okay, this is a very significant finding and it changes the care pathway for someone. But I think actually one of the most exciting and interesting aspects actually of all this data being generated is that now we can have truly normalized statistical priors for very big parts of healthcare. For example, like having the top decile of the population that's at highest risk for a cardiovascular event can be a very important statistical prior that can apply across a population without driving any immediate intervention as part of generating the data. But then any other signal that comes in could actually take you above that threshold. And so I think that transition is one of the most interesting aspects too of this window of time that we're operating in more stateful model effectively as opposed to completely stateless.
Yeah, and the sort of cost considerations as well are something we really always need to be bearing in mind if we're going for countries that have less budget available for this. So really making these things accessible, not just to countries that can afford expensive tests.
So actually my question relates exactly to that, because your nanoparticles, as far as I understood, are created in the lab. What is the route from there to mass production? What are the cost implications? What are the license implications? All of those different barriers that exist.
What we're aiming for is to end up with tests that would be at under $1 as a cost point, because I think otherwise they're just not going to be able to be used in a widespread enough manner. So the ones that are specifically around infectious disease, we're aiming for the under $1. Yeah.
Those one, are we at time? Okay. Great. Well, thank you very much. Oh, did you say there was one more time, or? Okay, great. Okay.
She's saying,
great. Thank you very much. Thank you so much for running us through your work. That was really fascinating. Thanks, everyone.